Good afternoon. I'm Mireille, Scientist and Associate Director of the Wilson Center, and on behalf of the Wilson Center and the Center for Faculty Development, I'd like to welcome you all to Best Practice in Education rounds. Please note that this session will be archived on the Center for Faculty Development website. Also, if you wish to see a live transcript of today's session, please turn on your closed captioning at the bottom of your Zoom screen. I'd like to begin with an acknowledgement of the land on which we work, study, and live. We recognize that many Indigenous nations have long-standing relationships with the territories upon which the Center for Faculty Development and the Wilson Center are located that precede the establishment of the University of Toronto, Unity Health Toronto, and the University Health Network. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. We acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississaugas and Chippewa bands. Since these rounds are a virtual gathering, a singular land acknowledgement does not capture the richness of our distribution across many locations. There are a few places on Earth that someone before us has not called home. I encourage you to consider your own position with regard to the land where you find yourself. And if you're not sure how to locate the Indigenous territories, treaties, and languages that shape both the past and present of your current location, I invite you to take a moment now to look it up. One of the benefits of this virtual format is that we can make use of virtual resources. Take a minute to open up another browser window, type in native-land.ca. It is a crowdsourced interactive map built around principles of land as pedagogy. The intention is to use these resources as an opportunity to critically engage in discussions about colonization, land rights, language, and Indigenous history. Land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First People and settlers. It's my great pleasure today to introduce our chair for the session, Dr. Ayelet Cooper. Dr. Cooper is a colleague of mine and a scientist and associate director at the Wilson Center and an associate professor in the University of Toronto Department of Medicine. She practices medicine within the Division of General Internal Medicine at Sunnybrook Health Sciences Center, where she attends on the clinical teaching unit. She's interested in the kinds of knowledge and knowledge production practices we see as legitimate within medical education and medicine more broadly, and in the ideas, individuals, and groups that are included or excluded based on their knowledge claims. She has published over 80 peer-reviewed papers, many of which relate to power, equity, inclusion, and social justice. Her pronouns are she, her, and hers. I cannot think of a better person to guide us through what I'm sure will be a stimulating discussion with the wonderful presenters who have made time to be here with us today. Ayelet, over to you.
Thank you so much, Maria, for the lovely introduction. Before we begin, I just want to give a few housekeeping details. If you have a question, please use the Q&A box. I will be monitoring it throughout the session, and I will give our presenters an opportunity at the end to answer as many of the questions as possible. Please ensure that you fill out the short evaluation that will be sent to your email at the end of this round. Your feedback is very important for the ongoing improvement of our beeper rounds. And with that said, I'd like to introduce our fabulous speakers for today's session, who I'm proud to know both of them, and I know they're both wonderful people and excellent speakers. Dr. Javeed Sukhera is an associate professor of psychiatry and pediatrics at the Schulich School of Medicine and Dentistry, Western University, Canada. He is also a scientist at the Center for Education, Research and Innovation at Western University. He practices in the pediatric chronic pain and child and adolescent mental health care programs at London Health Sciences Center. His interdisciplinary research program explores novel approaches to stigma reduction and bias recognition and management in health professionals. He is routinely interviewed by local and national media for his expertise on bias, stigma, equity, and wellness. He's also involved in numerous committees and councils at local, national, and international levels. He's the chair of the London Police Services Board, a former member of the Association of American Medical Colleges Board of Directors, and past president of the Ontario Psychiatric Association. Welcome virtually to Toronto, Dr. Sukhera. Dr. Mireille Norris is a Black Francophone woman physician born in Haiti. She started her career in healthcare as a McGill-trained physical therapist with a minor in psychology. After 3 years working as a community physical therapist, she started medical school at the Université de Montréal. Her training would take her on a journey which includes an internal medicine specialty residency at the Université de Montréal, subspecialty training in geriatric medicine at the University of Toronto, a master's degree in hospital administration from the Dalla Lana School of Public Health at the University of Toronto, and a certificate in quality improvement and patient safety, also from the University of Toronto. She's the medical education director of the hospitalist training program at Sunnybrook, which earned a reputation for preparing many underrepresented physicians to care for hospitalized patients with complex medical needs. She's also the geriatric medicine site lead for postgrad medical education in geriatric medicine, and the division lead for QI and patient safety here at Sunnybrook, where I get to work with her all the time, which is wonderful for me. This year, she was nominated as the first Department of Medicine faculty lead for Black and Indigenous resident application and mentorship, and is currently a member of the Sunnybrook President's Anti-Racism Task Force. Finally, she is the proud mother of 3 adult children aged 26, 23, and 20. And now I'll turn it over to Mireille.
Thank you, Ayelet, for this kind introduction. So today we'll share stories. I'll share 2 stories with you. My colleague, Javeed, will help us understand the issue, and then we'll wrap up with consolidation and discussion. Here's a picture of me when my son was between 6 and 7, and his sister was between 3 and 4. My ex-husband is present also. Over the next 10 minutes, I'm going to share with you a small slice of the good and the ugly of being a Black mother advocating for her child. And I'm going to compare that to the experience of doctoring while Black. My first story is deeply personal. While many of you know me as a physician, the most challenging aspect of my journey dealing with racism was what I encountered as a mother advocating for my child while navigating a healthcare system that made me feel victimized as a Black mother, seeking help for a mixed race boy with behavioral and emotional issues. I emphasize mixed race as I'm obviously of African ancestry. However, my husband is white of Ashkenazi Jewish ancestry. And while we bonded over a common history of transgenerational trauma, when I was advocating for my son, I faced racist barriers that my husband did not see or appreciate. My son was identified early at the age of 7 as having an exceptional IQ, but low emotional intelligence based on psychoeducational tests that had been triggered by multiple emotional outbursts in the classroom. His behavioral problems were framed by educators and social workers as a failure of my mothering skills and of our family dynamic. By the age of 11, he started showing signs suggestive of depression. I took him to a psychologist at North York General. My concerns were dismissed. He was not referred to a child psychiatrist, even though his school teachers were worried that he had suicidal thoughts and even thought that he had health problems documented in his records dating back to age 7. Our family broke up. We're under strain in this picture. My son was 14. Guided by a social worker, we made the fatal decision that he should join his father, who wanted to leave for Ottawa. There, my son's mood worsened. His father was depressed. He was left unsupervised. He went on to drop out of school at the age of 16. During the next 3 years, his academic performance would go on to further deteriorate, even while in Toronto under my supervision. This led to a plea for help, which eventually led to an admission in psychiatry to the emergency room. My son was clinically depressed and expressed those feelings to the emergency room doctor. I was there with him and his sister overnight. He had not been eating. He would not maintain his hygiene at home. I would find him sleeping on the floor in the dining room. After 10 days on the adult psychiatry ward, my son was told that his emotional problems stemmed from his relationship with me. His discharge summary read, ADHD and academic failure as the reason for 10-day hospitalization. This is the geriatric equivalent of failure to cope, or otherwise called failure to diagnose. Eventually, neuropsychological tests showing depression would be ignored by the psychiatrist. A psychoeducational assessment done after that confirmed a serious learning disability and a mood disorder as working diagnosis. My experience left my son with a deep distrust for doctors and damaged our relationship. 6 months later, advised by a social worker, I called the police, and my son left our house to a shelter, followed by admission to Covenant House, where he spent a year. 3 years later, I called the police again. He was taken to CAMH. Finally, a woman psychiatrist recognized the signs of psychosis and validated my concerns. My son was put on disability support for over a year. He received counseling from a diverse interdisciplinary team, which included a racialized psychiatrist of Sri Lankan origin with whom he connected. This intervention helped us heal. This is a picture of us last year in Kingston. I share this very painful story to illustrate to you how my son and I were victimized, how bias led to minimization of severe mental health problems, and a dramatic drop in academic performance and distrust of mental health professionals and delay in treatment and intervention. The information to intervene earlier was present and documented, but the cry for help was not answered until serious damage had occurred. Healing occurred when a set of circumstances facilitated the intervention of a diverse team which connected to us as people who mattered. Now I'll share the second story. In this story, I want to share what it was like to be a Black medical student at the University of Montreal in 1988 and a resident there until 1996. I will show that having worked during medical school because of lack of financial support as an underrepresented medical student can be an asset. I hope to show the silver lining associated with the struggles of being racialized, but also the need to trust your instinct when you feel that racist systems are keeping you from actualizing your potential. In 1998, I started medical school at the Université de Montréal. The AIDS epidemic was raging, and the city was notorious for having a higher prevalence of heterogeneous HIV. In those early days, the message that was disseminated by the media was that HIV was associated with Haitians, homosexuals, and hemophilia. I was born in Haiti, and Montreal has one of the most important Haitian communities in North America after New York and Miami. I first trained as a physical therapist and worked as one throughout medical school until the first year of residency. On the weekends, I provided respiratory physical therapists at the Montreal Hospital Chest Clinic affiliated with McGill to patients in the intensive care unit and those with chronic lung conditions. Most of my medical school peers would have started their clinical clerkship only by the fourth year of our 5-year program. It was necessary for me to work during medical school to support myself, but it provided me with the advantage of clinical experience that my peers did not have. This experience led to my performance during clerkship and residency to be considered exceptional by the supervising faculty I interacted with. One particularly memorable example involved a patient afflicted with AIDS. He was Haitian, Black, poor, terribly sick, and frightened. The man would go on to die rapidly during my rotation, in a matter of 6 weeks, of a rapidly progressive dementia. The care of this patient was put mostly in my hands as a resident. There was no available treatment in those days. I was his advocate, and I was present with the family when he died. While this experience was emotional, I felt a deep sense of purpose, being able to provide person-centered care at a time when such a terminology was not used. Antiretroviral therapy became available only at the beginning of my residency in 1993. In 1995, I applied for subspecialty training in geriatric medicine, and the medical school that knew my performance made me feel like I was not valued. A medical school in Miami was offering me a prestigious residency position in neurology after only a 4-week elective. Meanwhile, the school that trained me for 8 years made me feel unappreciated. After watching on the news, Jacques Parizeau announced that the defeat of his separatists in the Quebec referendum was the result of money and the ethnic vote, I sent my application to the geriatric medicine program at the University of Toronto for a PGY4 position. Dr. Barry Goldlist would advocate to have me join the program exceptionally in January 1996, as I had been delayed due to a maternity leave. For me, equity meant being recognized as worthy and having an ally who was willing to advocate for changes that would allow me to start residency 6 months later. This had not been done before, and other programs in Ontario were not willing to accommodate my need. Feeling included in the Division of Geriatrics is what allowed me to develop my career, and I have been told that my example has inspired other underrepresented student, resident, and physician. Joining this community has allowed me to serve French-speaking and Afro-Caribbean Torontonians who are often underserved and who provide immense cultural richness to the Toronto fabric. Thank you for listening to my story. Now I'll pass it to Javeed.
So the first thing I want to do is honor Mireille and express my gratitude to you for bringing so much of your personal and professional experience to the table today. As you'll see in our talk, and as is the nature of this topic, personal and professional are truly intertwined. So I also think we need to think about that as we enter this space together today. We should be entering this space with intention and asking ourselves if we're here today to learn about this topic because we want to feel good, or if we're prepared to move and work towards something better. Let us also honor this collective moment in our history. We must ask ourselves, why? Why are we talking about this topic now? Inequity, racism, bias, this is not something that is in our remote past or history. It is ever present. The inequity that we're talking about is demonstrated through persistent disparities in access to care, quality of care, and healthcare outcomes. Race and racism are major social determinants of health as they relate to access and quality of care. So let's think a little bit about the terms we're using, what they mean, and why. The title of today's talk is about bias and belonging. Now, bias is a term that's used generally to refer to preconceived notions based on beliefs, attitudes, or stereotypes. But discrimination is the treatment or the behavioral component. Bias itself as a concept is enacted through our behavior. There are also several other terms that are thrown around. These terms are often used as buzzwords in performative ways that don't truly reflect what they mean and why they matter. We talk, for example, of equity, which is simply addressing disproportionality. We talk of diversity, which speaks to diverse groups being part of something or organization. We talk of inclusion, creating spaces where people feel included and are invited. But the heart of the talk today and the heart of Mireille's story is about belonging. If we invite people of diverse identities to be part of our organizations, part of our communities, are we also permitting them to be openly and authentically themselves? Or are we explicitly and implicitly making them have to self-censor or not truly be able to participate as their unique self? Terms like equity, inequality, justice get thrown around, and many of you have seen graphics similar to this before. When we talk about unequal access to opportunity, Equality simply distributes these resources evenly. Equity speaks to custom tools that identify and address inequality. But if we're talking about belonging, we're also talking about justice. The concept of justice is about structural change. It's addressing these disparities by creating system and structural solutions to offer equal access to both tools and opportunities. So how do we define race? Well, Dr. Camera Jones, a leading physician advocate and public health researcher, highlights for us that race is a social construction. Yet, science and medicine have frequently tried to use race as a proxy for biology and genetics. Racism is a product of when we use race as a basis of structuring opportunity and assigning value. Yet in truth, there's clear evidence that race is not a genetic concept. There is as much or more genetic diversity within a racial group as there is between racial groups. Since race is socially constructed, it also has profound implications and impacts on social inequality. And that's not because of purely biological differences. We can see how there are historical definitions of race that have been shaped by science and medicine. For example, words, terms, language, discourse has been used to shape certain practices. It shapes our thinking even to this day, and it's baked into our laboratories, our bricks, mortars, and the very earth that we walk on. But we also talk about how this happens at different levels. And it's important to know, as Dr. Kendi states, institutional racism and structural racism and systemic racism are redundant because racism itself is institutional, structural, and systemic. We can see it manifested in the middle as something personally mediated through biases, stereotypes, and labeling. We can see it manifested structurally in how we design policy, who we admit, how we admit them, and how we make decisions. But it can also be internalized. And that's really part of what belonging is all about. When certain groups, whether they're part of our organizations as people who work in them or patients who are seeking help and assistance, experience persistent biases and discriminations, they become sensitized to that and they internalize those stereotypes, which can have profound implications on help seeking, trust, and mistrust in the system. I'm going to pause for just a moment and invite you to think about your own personal and professional identity. How have you been made to feel like you belong? How have you been made to feel like you don't belong? Draw upon your personal and professional experiences, not only working in the system, but also seeking care. Did you feel any evidence of bias manifested in the system, or did you not? Have you, in your personal and professional life, ever experienced a time where you felt keenly different from others around you? How did that impact what you think and believe? What groups do you believe you belong to? And how do those identities shape what you believe about yourself and one another? Institutionally, racism might manifest in material ways. It might be even visible. And on paper, we might think that we are quote unquote colorblind, but that's a highly problematic way to approach the issues. We know that institutional racism is based on longstanding beliefs and biases that we've developed as a society that might value or devalue certain groups compared to others. Being part of the system, we enact it just by virtue of being part of that system. And sometimes resisting it can feel like swimming against the current. We see health disparities and the evidence is clear. We can see inferior pain treatment, lower rates of certain cardiac procedures, fewer prescriptions, and the list goes on and on and on. But when we think about personally mediated racism, this can be both overt and covert. Oftentimes, in covert ways, it can be rooted in implicit biases that influence us outside of our best intentions and outside of our conscious awareness as well. This can lead to discrimination, things like prejudice, differential assumptions about abilities, motives, and intentions of others. It can lead to discrimination, differential actions towards others according to their race. It can be acts of commission, but also acts of emission. And it can be just as powerful in presence as it can be in absence. And when we reach the point of internalized racism, we see how damaging it can be because it results in self-devaluation, resignation, helplessness, and other terms like stereotype threat or imposter syndrome, which is also something that's gaining more mainstream understanding. These unpleasant psychological experiences of confronting negative stereotypes about ourselves, whether they're racial, related to gender, sexual orientation, social status, they can actually take up cognitive resources for us in the system. They can impair intellectual functioning and interfere with our ability to learn and work. So with understanding that context, I'm going to talk briefly before we launch into discussion about what we can do about this. Part of my own lived experience reflected through training, education, and personal journeys, a challenge early in my career. I reflected on the inequities that I observed around me. The inequities, for example, that might be racial or gender-based, but also major inequities in terms of how we treat patients with mental illness and substance use challenges compared to patients with physical illness. But as I reflected on the ways in which we think, teach, and learn about these topics, it was clear to me that it was framed in a problematic way. And I'm sure we can all appreciate it. We spend so much energy emphasizing that we, perhaps the 211 participants logged on today, are not biased. We're not biased. So let's use teaching and education to get all those other biased people together so we can help them be not biased. But what this leads us towards is counterproductive and coercive cycles of blame and shame. We see this all around us in terms of the polarization of discourses on bias, equity, and compassion. The truth is, my original idea to lean into this work came from the concept that if we're using up so much energy and using it up counterproductively in these cycles of blame, shame, us versus them, what happens if we change the frame by looking in the mirror at ourselves instead? So our research started with this idea. It started with holding up the mirror to health professionals, giving people feedback about their biases, and seeing how people process and integrate that feedback. But we were struck by what we found. When you hold up that mirror to a health professional who has a high expectation of themselves and one another, and you say, there's this thing called implicit bias, and despite your best intentions, it might actually lead you to enact discrimination. It was not met with warm and fuzzy feelings. Participants were clear that they did not believe that they could be biased. They struggled with reconciling this feedback about themselves. They emphasized that they can't possibly be biased, and anything that suggests that they were had to be wrong because they were professionals, and professionals can't have bias. Yet, they acknowledged that they're also human beings too, and that of course they have bias. Why this struck me in the early days of my work was I truly believed that a shared common human identity could be the seed that we plant to engage people in conversation, contact, and movement towards justice. But what I was struck by is that there's something about our training and our culture that actually encourages us to compartmentalize our identities as a form of self-protection. If I felt that the answer lay in humanizing interactions and healthcare education, training, and culture dehumanizes us, maybe we've got a bigger problem. Dr. Kendi speaks of this when he says, they are responsible for their racist ideas. I am not. I am responsible for my racist ideas. They are not. To be anti-racist is to let me be me, to be myself, to be my imperfect self. Our work found that the ways in which we frame discussions about equity, bias, justice has to consider the toxic perfectionism that we are surrounded by, our obsession to be right, to do everything perfect. If we continue to move in this direction, we found that simply giving health professionals feedback about their bias actually led to increased helplessness, increased frustration, and a sense of futility. It was only by giving people actionable things that they could do to mitigate the impact of that bias within their professional context that we saw things move forward. The model that came out of our work looked like this. It emphasized that our biases are blind to us, they are blind spots. So we must start by holding up the mirror and actively seeking feedback. Feedback from patients, feedback from teachers, feedback from our team members. Creating intentional environments where we cultivate that feedback and check in on how we're doing, making sure we're creating space. With that feedback, we move to critical reflection. And that means really taking a deeper understanding of what our biases might mean for our job and the outcomes that our patients might experience. And from there, it's about behavior change. It's about setting new explicit goals and role modeling that behavior. But when we evaluated this longitudinally, we found two key ingredients that would make this more successful versus less successful. The first was the degree to which people who learn together on teams work together in those same teams. There was something powerful about learning together in an interprofessional team because it opened up conversations about vulnerability. And over time, team members became social reinforcers for change. The other key concept relates to progress versus perfection. It emphasized that framing such interventions has to reflect that we can strive to be better. We can strive for that ideal. But unless we explicitly and intentionally accept that we will stumble along the way, accept our shortcomings and vulnerabilities, and I would even say embrace that imperfect self, we can't move forward. Otherwise, we'll burn too much energy in self-blame, self-criticism that hijacks the process. And that's why our work has found that self-compassion is a key ingredient to advancing us towards justice. How hard can we be on ourselves in healthcare and society at large? How easy is it to fall back into cycles of self-blame, self-criticism? How can we sometimes unintentionally take up space to emphasize our goodness and our good intentions versus being able to step back and create space for others? One of the tools that I highlight in talks that I give comes from a bias expert, Howard Ross, who speaks of the idea of taking a literal and figurative pause when bias might manifest in our learning and workplace environments. So often we see these emotionally charged moments happen in so many different ways. But the truth is, when we see something manifesting, it is simply the tip of the iceberg. It is our job to reflect in that moment when we see something clinically, all the structural ingredients that might be contributing to what's really happening versus what we see in front of us. And that requires us to take a literal and figurative pause, to reflect on our interpretations and judgments in that moment, and understand others' possible interpretations and judgments. It requires us to not fall back into a power struggle or a coercive cycle, but to seek a path forward that elevates and dignifies all involved. And there's a whole literature on bias mitigation that I can't get into in detail. It emphasizes things like counter-stereotype imaging, imagining the opposite. It emphasizes mindful practice training, individuation, working hard to see each unique patient or colleague as a unique and complex human rather than a stereotype or label. The literature calls for us to practice empathy, putting ourselves in each other's shoes. But I would say my work and experience really emphasizes three key pieces. And the first is courage. If we are part of a biased system, speaking up about bias takes courage. It took courage for Dr. Norris to bring her full self to the table today. And I thank her for it. Because the truth is, we can't move forward without discomfort and without dissonance. Now, that doesn't mean that people should put themselves in danger, and any education has to be commensurate with accountability. But it does mean that we have to be willing in our spheres to step outside of that comfort zone, to speak up, to challenge, and to have the courage to do so. But what it also requires is the courage to be vulnerable. We can draw to have compassion for others, but if we do not actively practice self-compassion, self-forgiveness, we will not be able to fill our tank in order to do this work. The other thing is recognizing that when we find ourselves in these encounters, we are designed to avoid them. That's the way this works for our brains. Being aware of that avoidance, the implicit avoidance behavior that accompanies complex situations like this, can help remind us to lean in instead of avoiding, to seek connection by leaning into these moments of discomfort and dissonance and really engaging in as much dialogue as we can while maintaining safety for ourselves. But all of this requires more than just individuals. How much do we blame individuals for system issues? How much do we try to address wicked system problems by training people in workshops? The truth is, we need individuals to be a part of it. But like Dr. Kendi says, changing minds is not a movement. Critiquing racism is not activism. Changing minds is not activism. An activist produces power and policy change. If a person has no record of power or policy change, then that person is not an activist. Yet the discourse that we have when it comes to individuals versus organizations can also fall into the polarizing cycle of us versus them. We cannot and should not look to others with who we perceive to have more structural power to make changes. We are part of our organizations. We are part of society at large. And it is our job to work within our spheres of influence, to harness the power we have of influence to co-create social change within our organizations and communities. But we can't do it for free. And we have to be mindful of the emotional labor that's involved in this work. We have to be mindful of existing paradigms in academia that often create committee structures that are tokenistic and performative and rely on Black, Indigenous, and racialized faculty to do the work. The work shouldn't be free. There are experts in equity, diversity, inclusion, and belonging. There are experts in critical race theory. We should be honoring that expertise. We wouldn't expect people to simply give classes on nuclear physics without ensuring we had someone trained in the topic. So it must be clear that addressing policy practice in organizations requires a commitment to critically examine and reform activities and to fund that and evaluate that. It cannot be something we do off the sides of our desks. We must also recognize that in many ways, our tendency tends to fall to hoard power, to keep power within certain spheres and not share it. Yet sharing power is the key to advancing justice. And sharing power also comes with loss that requires reconciliation. So we need not only to create safe spaces, but brave spaces to be able to dance with this kind of discomfort.
Thank you so much, Javeed, for that incredibly impactful talk, and to Mireille for your fabulous stories. And I'm just sitting here taking a moment, reflecting on everything that I've heard. We have a couple of questions in the Q&A, and I'd encourage you guys, everyone in the audience, we have, I think, 213 people here, so I'm sure there are lots of questions, to put some questions into the Q&A box. And And I'm going to let the CFD staff is going to answer the question I think everyone has about access to the recording afterwards. I think there's going to be lots of people who want to know that. So I believe Samina is going to put that information into the Q&A box for anyone who wants to know the answer. So I'm going to start with a question from the Q&A box. How do we balance self-compassion with accountability? I understand the rationale behind the idea of self-compassion, I think is what they're trying to say, but I'm concerned about the level of ongoing forbearance required from those in our society who are continually victimized by racism, implicit or otherwise. And I'll either or both of you, whoever wants to respond.
I can start if that's okay. So this is a very important question. I'm glad this was asked. It isn't mutually exclusive. I think we have to recognize that there is a mutuality in which we do things in teaching and learning in medical education. When we encounter a learner in difficulty or someone who's struggling, we recognize that there can be a tendency for us to say that we are not part of the problem, and therefore we are not part of the solution. By no means is anything that I've suggested or offered from the work that we've done suggestive that we shouldn't be having accountability, that we shouldn't be improving regulatory structures, especially when it comes to discrimination and harassment policies. I'm part of a team, for example, where we're doing a project looking at discrimination and harassment policies across Canada. And what's clear and what we're hearing loud and clear is that we are very poor at accountability, particularly in academic medicine. The performative nature with which we approach these issues can actually perpetuate harm and lead to further violence, where the disproportionate burden of reporting and speaking up when people encounter harm falling on people who are experiencing it, who are tacitly encouraged to remain silent, lest they be labeled as problematic or disruptive. With that in mind, the lessons that we have from our work really accompany the idea that disruption and dissonance must be accompanied with dialogue for change. Theories, for example, of transformative learning, concepts like restorative justice or truth and reconciliation speak to acknowledging hurt while moving towards healing. And I think that that's a really important concept that should ground this work, because it's always going to be easier sometimes to focus on the hurt. That doesn't mean we shouldn't honor it. It doesn't mean we shouldn't validate it. But what was key in some of the stories we heard today was that healing happened. It took one transformative moment to break that cycle. And that's why it's important to remember that these concepts aren't mutually exclusive, and we can resist tendencies that push us away from recognizing that two seemingly opposite truths can coexist, and in fact do in reality all the time.
Thank you. Mireille, is there anything you want to add to that? I will just pop in while you're thinking about it that we have a comment for you that is, I don't think you have to answer, but someone just wanted you to know, Mireille, merci de votre courage. Thank you for your courage. So I'll give you time to think. And so now if there's anything else you wanted to respond.
Well, I wanted to talk about compassion and the notion of internalized racism. You see, so when you internalize racism, you kind of accept that, well, you know, you shouldn't be aspiring to better than what you're having. So, you know, so you have to have compassion for yourself, for this defeated attitude, and understand where it comes from. And, you know, in my case, I had to have compassion as some of the decisions that I made were draconian, were violent. And it was a lot of trial and error. So the healing occurred in the space of dialogue, and I have to acknowledge the support of, you know, family members and friends who were in healthcare to help me through this process of healing, which meant having compassion for myself, but also compassion for my son and the rest of my family member, including my husband. Well, we've worked that out.
Okay, I'm going to combine I have two questions that have sort of come in, one in the Q&A and one in the chat. One is someone's asking about even racialized learners who say, oh, I've never encountered racism. I guess I've been lucky. What are our roles of educators in these situations? This is from someone who says they've been doing anti-racism work for a long time. And the other question is, what do you do with colleagues, institutions, friends who aren't the 213 people on this call? Because the people on this call have selected to come here because most of them probably think this is important. What do you do about the people who don't see bias as real or worth diverting time, money, or energy to the effort? What approaches or tools do you suggest when you counter pushback from either of those communities?
Well,
some easy questions today.
Let's tackle each of them one at a time, okay? The first is about opposition, the people who don't see this as something important. I think that at times there is critique that we really do need to lean into. We can often fall into dogmatic approaches, but it isn't until we engage with some of that resistance, we can't really appreciate how we can tackle it and move it forward. However, there also is the need for structural change and accountability. And I know that the phrase new normal gets thrown around a lot in COVID, and I have like an aversion to it. But I look at this as co-creating a new normal. You know, if we look at the literature on psychological safety, what does it emphasize? It emphasizes that organizations that are psychologically safe aren't warm and fuzzy. They're organizations where dissent and critique is normalized. And that's why I think we need to normalize a constant iterative cycle and struggle towards improving equity. You know, our literature has normalized it. The healthcare quality literature highlights equity as a key component of healthcare quality. So we need to normalize social justice as not something that's a fringe or a passion project or a trend, which is highly problematic, but as an essential component that if we do not address, we will cost human lives and cost suffering. By normalizing it, you create a critical mass where some of these people who are late adopters will just have to jump on board because it will become part of that normal. The other question in terms of, I almost forgot it because I spent so much brain energy answering the other one. What was it about when we encounter the comment, right? That I've never felt it or seen it. We can have lots of tendencies in that space, right? What is our tendency? Let's pause for a second. Our tendency, especially if we've encountered it, is stepping into that space, right? It's bringing our encounters and how invalidating that comment can be for us into that space. And I would challenge us to think about that and reflect on that, because teaching and learning isn't about taking space. It's about creating space. And we see that in some of the literature on feedback as well. How can we engage this learner or colleague, leveraging our existing relationship with them to really better understand what they mean by that and how they have to recognize how that might be perceived by someone who has encountered it. What does that feel? Could it feel like gaslighting, which is a form of abuse? Could it feel invalidating? But it's through that reflective questioning and dialogue that we can engage in it. And it really does require that we recognize that implicit urge and need normal thing we do, which is taking up that space. Now, we all know, of course, that just because someone doesn't experience it doesn't mean that it doesn't happen. But what we also need to know is that different people hurt for different reasons. Different people build defenses for different reasons. And for some people, even racialized people, they are guarded and defended against topics of this nature because of, again, things they've done to defend themselves against that dissonance in a self-protective way over time. Everyone we know is struggling. Everyone we know has experienced vulnerability in different ways. And the more that we look in the mirrors across our society and at ourselves, the more we can engage with one another at that human to human level.
I'm going to add that there are some beautiful words, not questions per se for most of them, but some lovely words for Dr. Sukhera and Dr. Norris in the chat. I'm not going to read them all out loud because I'll embarrass them. if they have a look here. I'm going to move to a question that is primarily aimed at Dr. Norris, but for both of you as well. This one says, thank you for your courage in sharing both your stories and visions. Brilliant talk. I was wondering if Dr. Norris can speak to the burden she has shouldered as a Black female physician, mentor, and leader, and whether she feels the tide is shifting in the institutions to support her work. Are there more resources and non-tokenistic anti-racism policies coming to fruition? What support are you given? Is there a commitment to allyship, and what does institutional allyship look like?
Thank you for this question. Things have changed hugely. You know, I mean, you can see my son is now 26 years old. So, you know, and I've been here for 26 years old. So in this new position where I've been appointed faculty lead at University of Toronto, I've been appointed based on lived experience. I have not published in an academic way about this, and I was quite humbled by this appointment. And when I'm part of that group, within that group, I see the diversity reflected, and I'm in the way people interact with me, I see my opinion validated as such that I'm sought out for that lived experience and for this advice. So I definitely see a shift, and I'm very hopeful for what I see. And I also see the willingness for people to be vulnerable, the willingness for people to share their story, and that delves outside of racism within the whole idea of physician wellness. I hope I've answered your question.
I'm going to move. You talked a little bit about people who are willing to be vulnerable or people who are willing to be maybe uncomfortable. For both of you, Javeed, as you said while you were speaking, it's a normal reaction for people to want to avoid these kinds of feelings, these kinds of situations. What suggestions do you have, practical suggestions for people to tolerate the discomfort that they have when they're leaning into these, when they're leaning into the discomfort, when they're leaning into these emotions?
I will disclose, you know, I'm now an older woman, right? I'm going to be 58 this year. So I'm at a stage in life where, you know, I've had my share of trauma, and I've also taken my share of counseling, life coach, retreats on mindfulness, regular meditative practice, so that I have learned to pause. I have learned to be more in touch with those uncomfortable emotions and accept that they are informative, that they're a signal that requires me to reflect and engage so that I can be a better person. But it has been a journey. So I would really encourage people to adopt some of those healthy wellness practices that include meditation, and consider life coach and all of those ways to learn to be vulnerable and deal with those uncomfortable conversation and experience.
Yeah, I think that's exactly right. I agree with what was shared. I think, you know, actionable things. First of all, take it easy on ourselves. Recognize that the culture actually teaches us to cope with distress by doing more of the things that burn us out and cause that distress. And that means making time for ourselves. And that's going to look different for everyone. The other thing is you don't have to do it alone. In fact, there's so much more that happens when we engage in reflective dialogue, when we have places and spaces with people we trust that may not be at our same organization, that may not be in our same profession, where we can feel comfortable being vulnerable and just really relax and process some of this. The other thing about this is we should not be needing or asking people who are racialized to do it for us. I think that that can happen sometimes subtly and unintentionally. And I tell people all the time, because I get emailed and I'm active on social media, when they say, oh, can you say this or teach me? I say, well, I can't be a Google search for you. You know, this is a topic that there's lots of literature on. I encourage you to do the work. So being aware of that sometimes emotional burden that we place on our colleagues who are different from us to teach us can be problematic, because really what we need to be doing is creating time and space for us to do that work before we rely on others in that way.
I'm going to move to a question that was asked a little bit earlier. This may resonate with you, Javeed, because the person asking tells me he's a child psychiatrist. So is it, which in case people missed the introduction in the beginning, that's what Dr. Sukhera does when he's doctoring. So is it possible to speak to invisible minorities and increase prejudice towards some people even within their own communities? Like LGBTQ people of color increase prejudice in their own communities. How is this addressed? How do you bring more attention to this area? As a child psychiatrist working with LGBTQ people of color, like POC children who are bullied and harassed, it is often difficult to find resources or approaches to work with these populations. It's even more difficult to address in educational settings.
Well, great question. One of the ways in which I recognize that are really two key points. The first of all is a common assumption that by our human nature, we all know what it's like to have experiences of vulnerability and experiences of adversity, and knowing what it feels like to not belong. And that means not then passing judgment about what may be seen, visible, or invisible. In fact, really explicitly acknowledging that discrimination and inequity can at times be visible, which takes on a different form when it's racialized versus invisible, but still can include experiences of trauma. But the second piece I use is, I rely on critical race theorists who've been doing this work for decades. And if anybody's read the work, the foundational work of people like Kimberly Crenshaw, you can understand what it means to have a theoretical and methodological framework of intersectionality when we approach and consider how we sometimes see equity as one-dimensional when it is really much more multidimensional. Sadly, intersectionality has also become a buzzword, and often people throw it around without understanding the conceptual underpinnings of the theory and why it matters to recognize that everyone in visible and invisible ways has intersecting forms of inequity that they may experience, while also being possibly a perpetrator of that inequity. That idea of recognizing that depending on context, we may simultaneously be someone experiencing oppression and someone perpetrating oppression is a really powerful way to free ourselves from some of that pressure and be able to recognize what it means to honor that vulnerability, validate it, while recognizing the dual identity that we might have.
Thank you, Javeed, for saying this, right? I come from a country that has quite a history, and the notion of internalized racism, but there's also the learned behavior from the oppressor, such that you then behave towards your kin in the same way as the oppressor has. It's so that's why the idea of being reflective, pausing, compassion, learning your own internalized bias, it's a lot of personal work that's needed. Some of the bias I've heard have been from my own kind. Thank you.
We have 1 minute left, and I'm so sad because we have so many amazing questions still sitting in the Q&A box that we could easily go on for another hour, which I will not do, but we could keep talking for ages. So I'm just gonna wrap up and say thank you all so much. Thank you to everyone who attended. Thank you for the phenomenal questions, and so sorry for the now 12 questions in the Q&A box that we didn't even get to. Thank you to our amazing speakers for their wisdom, for their insights. It's always extra amazing to hear people who you know and whose work you know, and to hear them bring you to new ways of thinking and new insights and new understandings about what they're doing and about their work. And just a fabulous session. So thank you both. I'll invite you all to the next Beeper rounds, which is taking place on the 23rd of March. where Stella Ing will be presenting on teaching for critical reflection. What, why, how, and does it work? I hope you'll be able to join us. I think it'll be an excellent follow-on to this session today. In fact, as you know, Dr. Sukhera even talked about critical reflection a little bit in his talk. And so I think it's an excellent tie-in for those of you who want to know how to move forward and teach in these kinds of areas. So thank you all, and have a wonderful rest of your day.